Good afternoon, everyone. I'm Dr. Moy, a clinical geneticist from Penang Hospital. So this is our clinic in Penang Hospital. We just started our service in end of the year 2019. So today I'm going to present to you the topic of global development delay, the indication of when to refer to clinical geneticists. So this is my content. I'll share with you 4 cases and we'll talk about what are the genetic tests, what are different genetic tests which are available currently, and how when we see a child with global developmental delay, how to investigate. So let us, sorry, can everyone hear me? Can?
Dr. May, we can hear you very clearly.
All right.
There's no complaint from the chat box. You may.
All right, good, because I can't see the chat box. So, okay, so before I start with the cases, let us get this correct. So, cells, we have the nucleus. So, mitochondria outside. So, inside the cells, we have chromosomes. We have 23 pairs of chromosome. So, and then inside the chromosome, we have this double helix DNA, which carries a lot of genes, nearly 20,000 genes. Which is the genetic material which decides the function, the regulation of the cells and organs. So chromosome is chromosome, gene is gene, they are different. No? So this is the first case. So this is a girl with multiple congenital anomalies and developmental delay. She was born at term, but she has cleft palate, micronatia, and some heart defects. And she has some preauricular tag and hypoplastic toenails. So because of the multiple congenital anomalies, karyotype was requested in the newborn period. So the karyotype came back as abnormal. So she inherited extra chromosomal material from the mom. So father has a normal chromosome, but mom is a balanced reciprocal translocation carrier. So reciprocal translocation involves the breakage of 2 non-homologous chromosomes and the exchange of fragments of the chromosome like this. So the incidence of translocation carrier is about 1 in 500, and usually these people, they are normal, they're healthy, they do not have any active medical problem. But sometimes they may have problems with difficulty in getting pregnant, or they have recurrent miscarriage. So karyotype must be performed on couples who have 3 or more pregnancy losses to detect translocation carrier. So remember that when we check translocation carrier, I mean when we order karyotype to look for translocation carriers on the couples, so we check both the father and mother. So this last time I had a case where they only check the mom. So usually we check both, right? So if let's say a person is a translocation carrier, each time when they get pregnant, they have a chance of getting a normal baby, or balanced translocation carriers same as them, normal, but may face problem in the future when they're having their own family. And also they have a risk of getting a child with abnormal chromosome, either trisomy or monosomy. Let us look at the family tree. So this is how we draw family tree. So usually we draw 3-generation family tree. This is the proband. So proband we shade, and then we put the arrow here. So this is the proband. Proband already passed away. So passed away, we put one cross, and one cross for those passed away. We don't put an X. So I have seen quite commonly our doctor put X for those passed away, which is not so correct. And then, so this is the mom. Mom is a translocation carrier. So when this carrier, we put a dot inside. So we put a dot inside. So the sisters have 2 miscarriage before. So so when we have a case of this, like the mom is a translocation carrier, it's very important to do genetic counseling, not only for the mom herself, also for the siblings. counsel them the risk of recurrence, risk of having a child with aneuploidy in the future pregnancies, and encourage them to have their karyotype tested so that they are aware of the risks. So, so for this girl who's normal, and here one boy, one girl who are normal and healthy, so it's important to provide genetic counseling and to test their, do a karyotype testing when they are planning for their own family after 18 years old. So you can see that not only she is a translocation carrier, 3 of the sisters are also having this balanced reciprocal translocation, which is not that uncommon, 1 in 500. So we provide genetic counseling for the family. We explain to them the risk of recurrence, and we give them the option of prenatal testing, which usually involves either a CVS or amniocentesis. So amniocentesis usually done at the gestation of 15 weeks, 16 weeks above, done by fetal maternal specialists under ultrasound guided procedure. They collect the amniotic fluid and send to overseas to look for aneuploidy. And then the risk of procedure is 1% of miscarriage that we must always inform the parents. And if let's say the results came back as abnormal, then the option of termination of pregnancy. So besides prenatal testing, we also explain to them the option of IVF and PGT. So IVF, after got an embryo biopsy done on the embryo, and then do the test to look for aneuploidy before implantation into the uterus for the normal embryo. All right, this is the second case. So it's a 12-year-old boy with intellectual disability. So this boy, he has fairly normal milestone initially, and but he failed all the subjects when he entered school. Otherwise, he's ADL independent. He has some subtle dysmorphism, long face and prominent ears. So investigation done include karyotype and IM screening, came back all was normal. So the pediatrician suspected Fragile X syndrome. Oh, wait, so okay, let us go to look at the family tree first. So so this is a 3-generation family tree. So this is the proband. So you can see that he has another 5 cousins who also have intellectual disability, and most of them are boys, 1 girl. So because of this family history, the pediatrician actually suspected Fragile X syndrome. So, and actually came back as this boy is having a full mutation repeat size of more than 200 CGG repeats in the Fragile X gene. So in this condition, because this is X-linked inheritance, it is important to check the mom to see whether the mom is a carrier or not. If the mom is a carrier, then each time she's pregnant, if she's pregnant with a boy, 50% is unaffected, 50% is affected. If she's pregnant with a girl, then 50% unaffected, 50% most of the time will be carrier, or sometimes mildly affected or as severely affected as boy with Fragile X syndrome. And we know that more than 200 CGG repeats is a full mutation, whereas 55 to 200 CGG repeats is called pre-mutation. So pre-mutation in males is associated with Fragile X associated tremor ataxia syndrome, where they develop some tremor ataxia during when they are adults. And for females with pre-mutation carrier, they are also at risk of getting this Fragile X associated tremor ataxia syndrome and Fragile X associated primary ovarian insufficiency. So in this case, it's important to refer to a genetic clinic for genetic counseling, not only for this family, it's actually for nearly everyone in this family. So for example, so it's important to check the mom here, whether they are they should be the carriers, and also here, and also when his siblings grow up. Here, the cousin grow up. When they're planning for their family, it's important to do genetic counseling and also testing of their fragile X status after counseling to know whether they have a risk of passing on the faulty gene to their next generation. So for here in males, we also can offer genetic counseling to the males because if let's say the males have pre-mutation in the FMR1 gene, then they have a risk of developing this tremor ataxia syndrome in adulthood. So in this case, even though we have already got a diagnosis for the child, it's important to refer on to for genetic counseling for the other family members. So the third case. So this is a 1-year-old 10-month girl, first child of non-consanguineous parents. She just have mild development delay because she just doesn't walk as at the age. So otherwise, she's not dysmorphic. She has normal tone, reflexes, and power is good. So the pediatrician sent off some blood, including the blood gas, the ammonia lactate, and thyroid function test, which will all come back as normal. However, the plasma amino acid revealed marked elevation of phenylalanine 1600. So do we know what does this girl have? Anyone want to try? Okay, never mind. It's okay.
So, is it phenylketonuria? Oh, yeah.
Yes. You're right. So this 1600 is very, very high. So this is a classical PKU. So this is a classical PKU. So two pathogenic variants found in the PAH gene. So in phenylketonuria, they have this deficiency of absent phenylalanine hydroxylase enzyme. So they can't tolerate, this protein intake. So the Phe will be very high. So without effective treatment, patients with this classic PKU, they develop profound and irreversible intellectual disability. So this is an autosomal recessive condition. So it's important to do genetic counseling. And most of the time, the parents are carrier and 25% chance recurrence risk in all the pregnancies. So when we say about this 25% recurrence risk, I always will add on with a sentence, explain to the parents, meaning that each time is a 25%. It doesn't mean that I have 4 children, one affected, the other 3 should be normal. Some parents, they think like that. So we must always tell them, if your luck is bad, they can have all the children affected with PKU because the risk is 25% in every pregnancy. So for PKU, it's important that they need a low protein diet, and we start them early for this Phe restricted diet. So they need a special milk formula. So it's important to get the Phe level control, and also especially when this girl grow up later, to have very compliance to the diet and also the treatment, so that the Phe level is in a normal range, in the optimal range, even before she planned for a pregnancy, because of the maternal PKU syndrome, where the fetus can have a microcephaly, mental retardation, or congenital anomalies because of the high Phe level. All right, the last case. So this Indian baby, parents are consanguineous. She has an elder brother who is healthy. So she was born at term, very well, no problem. And on day 4 of life, the mom noted that she has a neck swelling, and subsequently she was warded in the neonatal ward, found to have hypothyroidism, started the thyroxine supplement on day 5 of life. And she was discharged well and followed up in the pediatric clinic. So during the follow-up, she also has global developmental delay, hypotonia, and chorea. And during eye assessment, also found that she has bilateral optic atrophy and squint, and she has moderate hearing loss. At the age of 1, she already has a microcephaly, failure to thrive, and developmental delay. So the pediatrician ordered some investigations, which includes karyotype, the basics blood gas, ammonia lactate, and plasma amino acid, urine organic acid, and SR carnitine profile to look for inborn errors of metabolism. A brain MRI also done at the age of 2. So all came back as normal. So this time, no lung. All came back as normal. So in conclusion, she has severe global developmental delay. And because the parents are consanguineous, we counsel the parents possibility of autosomal recessive disorders, and risk of recurrence in future pregnancies will be 25% in all the subsequent pregnancies. So she has an unknown diagnosis. So we must always remember that unknown diagnosis, sometimes misdiagnosed, can be frustrating when we misdiagnose a patient. So she is actually having a rare disease. So rare diseases is actually more common than what we think. So in the US and in the European, they consider rare disease when it happens fewer than 1 in 2,000. In Malaysia, we consider rare disease that happens less than 1 in 4,000 in Malaysia. So there are more than 7 or 8,000 diseases are classified as rare, and most of the time it affects children. And more than 95% of the time, there's no FDA-approved drug treatment. And we believe that more than 80% of the time, the rare diseases are caused by the faulty genes. And in this world, more than 300 million people is affected by a rare disease. So in Malay, we call penyakit jarang jumpa. So rare disease, it takes a lot of years, more than 5 years, and visiting of more than 7 specialists before they get an accurate diagnosis. During this diagnostic odyssey, patients may receive unnecessary tests, procedure, wrong diagnosis, and experience delay in getting effective care. So accurate genetic diagnosis remains essential for informed care, patient and family well-being. So let us look at what are the types of genetic tests which are available nowadays. The technological advancement over 60 years has brought us from the identification of the cause of Down syndrome to the understanding of more than 7,000 rare diseases nowadays. So in 1960, we have karyotype, and 20 years later, we have FISH, fluorescence in situ hybridization. So FISH test is used to detect a microdeletion at a very certain specific location, which is targeted by the FISH probe. So for example, like DiGeorge syndrome, 22q11 microdeletion syndrome. So can use FISH test. And at the same time, we have Sanger sequencing. Sanger is used to detect single gene disorder. And after year 1990, we have chromosome microarray analysis, which can detect microdeletion and microduplication in the chromosome. So this is used to look for chromosome disorders. And after year 2000, we have next generation sequencing, NGS, which allows us to sequence many genes at one time, so which saves a lot of time and cost. So this NGS include targeted gene panel, exome sequencing, and genome sequencing. So over here, I put red color for a chromosome microarray and the NGS test panel, exome, and genome sequencing, because this is not easily available in our country, and patient or parents have to pay out of pocket for the test. So this table actually summarizes well the differences between all the different tests. So when we have a gene panel, basically it tests for a few number of genes, can be 1 or 2 genes, or a few hundreds of genes. Whole exome look for variants in the exonic regions, and whole genome is used to detect variants throughout the genome. So gene panel is actually part of exome, whereas exome is only 2% of whole genome. So 2 years ago, this ACMG, American College of Medical Genetics, actually published these guidelines, and they suggest that exome sequencing or genome sequencing can be considered as a first-line or second-line test for patients with congenital anomaly, developmental delay, or intellectual disability. So previously, when we see a patient with delayed development, we still take we took detailed history, family history, examination, and review the investigation, and we do a stepwise approach from one test to another test. So nowadays, when we see a child with global development delay, it's important to take still detailed history of the child and 3-generation family history, because we may get some clue from that, and complete physical examination and review whatever previous investigations or imaging that's been done to look for some extra clues from there. So it depends on the phenotype of the patient. If the patient, whether the patient has a specific phenotype or a complex non-specific phenotype. So for example, if you suspect this child have Down syndrome, or you suspect this child have a microdeletion like DiGeorge syndrome, so then you may want to request a karyotype or FISH test. If you suspect some microdeletion or microduplication syndrome, then chromosome microarray is needed to look for those micro changes. If you suspect this child to have a single gene disorder, such as Prader-Willi syndrome, or Angelman, or spinal muscular atrophy, then you may want to order single gene testing, which is available at IMR. If you have a child with neuromuscular weakness, you may want to order some targeted gene panel to look for the causes. And not to forget our inherited metabolic disorders biochemical tests, as we do not have a newborn screening in this country. If the patient has a complex phenotypes involving multiple system, multiple differentials, or you suspect a genetically heterogeneous disorder, or when there is a specific genetic test is not available, or this child has an unsuccessful previous genetic testing, like this Indian girl, or when you have a very critically ill or newborn child in the ICU, then you may consider whole exome sequencing or whole genome sequencing. So in Malaysia, whole exome, whole genome, targeted panel, and also microarray is not easily available, and they have to pay out of pockets themselves. So we continue with this girl. The story. So at the age of 3, she has basically severe global developmental delay, ADL dependent, hypotonia, chorea, optic atrophy, hearing loss, failure to thrive, microcephaly, and she basically has an unknown diagnosis. So we counsel the parents for whole exome sequencing, and whole exome sequencing detected a likely pathogenic homozygous variant at ATP82 gene. So with this, so actually this child is having this ATP82 recessive mutation, which causes severe hypotonia, cognitive impairment, hyperkinetic movement disorders, and progressive optic atrophy. So with these genetic results, we actually can look through the articles and to share with the parents what are the information available out there, how are the other children doing in the other parts of the world, and most of them, they are very, very severely affected. So accurate genetic diagnosis is very, very important for genetic counseling, and also explain to the parents the recurrence risk, which is 25%, because this is autosomal recessive disorders, and provide reproductive options to them, either prenatal testing or IVF with the PGD testing. And this provides clinical care, surveillance, psychological closure to the parents, emotional relief, and help them to get access to resources and support. So what are the diagnostic challenges with all these tests? This NGS test, exome, genome test, the most important one is still accessibility. This test is not easily available. So as I explained earlier, and interpretation of genetic result sometimes can be difficult as well. It is not common that we can have various of uncertain significance (VUS) in our reports, and then we will need more information and more time to really solve the problem, or even sometimes even extensive investigation and study also can't conclude. And remember technological limitation of each test. So when we get the negative report, we must always think of the limitation of the test. And sometimes with a positive result or uncertain result, it may cause additional financial burden because we need to test more family members, the parents, the siblings to get more clue. So this one means that the parents need to pay extra money. And sometimes with the positive genetic results, then we need to do more surveillance. So this also can cause additional burden to the family. Other challenges include insurance discrimination and also negative impacts on the family dynamics. So it is very important to have proper consenting process and genetic counseling before a genetic test can be done. So we always say genetic counseling must be done pre-test, before genetic tests carry on, and also post-test genetic counseling. After the test, so so let us continue the second part of the genetic results that this girl have. So for the secondary finding, she also has a heterozygous likely pathogenic variants in the RYR1 gene. So when we do a whole exome sequencing, occasionally we can have this secondary finding where they find mistakes in genes which are not so related with the primary condition, not so related with the presenting complaints of the patients. For example, they found a mistake in the cancer gene, in BRCA1 gene, which means that this child have a higher risk of getting a breast cancer when she grows older, but it's not 100%. So we must always explain to them properly. So RYR1 gene is associated with malignant hyperthermia susceptibility. So this can be precipitated by certain volatile NS or with the depolarizing muscle relaxant such as succinylcholine. So it's important that we also give them a card labeling this one RYR1 gene positive so that they are aware of this condition when they see doctor or during emergency. So with this whole exome sequencing, this ends the diagnostic odyssey for this child. So in conclusion, this child has two disorders, an autosomal recessive disorders, ATP82 related disorders is autosomal recessive disorder, and an RYR1 gene autosomal dominant disorders. So we counsel the parents, 25% recurrence risk here, and this is 50% recurrence risk. And it's important to test the parents for both the ATP-AA2 and the RYR1 gene, and also the siblings. So, so basically in clinical genetics, what we do is basically genetic counseling and genetic testing. So we counsel the patient before genetic testing, and then after genetic testing, we do another genetic counseling. So it's a post-test genetic counseling. So what aspects are covered during genetic counseling? So besides the taking history examination, we explain to them what are the type of tests which are available and which are the suitable tests that can be done and can be offered to the family. And when we have the result, we talk about the inheritance, the information, and also we provide support and psychosocial support. And also it's important to also sometimes do genetic testing and counseling of the other family members. So when to refer a child with global developmental delay. So detailed history and clinical examination remains a cornerstone in the evaluation of children with GDD. So we still very important to take history examination, examine properly, look for all the clues, whatever clues that's present, and genetic testing is essential in individuals in whom the etiology is not readily apparent. This when you don't have a diagnosis and you strongly suspect this child is having some genetic condition, then yes, please refer. Reaching a specific genetic diagnosis provides many advantages to patients and families, including an end of diagnostic odyssey. And this can enable us to give precise genetic counseling and optimize longitudinal management and targeted surveillance. So I want to advertise here that we are going to have a short course in genetic and metabolic somewhere in October 4th to until 6th of October. Is at Zekon Hotel UKM at Kuala Lumpur. Is organized by the HKL Genetic Department together with GCSM Genetic Counseling Society Malaysia. So early bird is cheaper here, 200 and 250 ringgit Malaysia. And for these 2.5 days, basically, we are talking on metabolic conditions and also a lot of genetic conditions. And this is my last slide. So, so the last day of February every year is actually a rare disease day. So next year is actually 29 February is a rare disease day. So this is the aim is to raise awareness and generating change for the 300 million people worldwide living with a rare disease, their families and carers. Thank you. Any questions?
Thank you, Dr. Moy. I think in the chat box, there's one question for you. I think most of us will be struggling with this as well because now we see a lot of cases of autism in our clinics. Would you suggest any genetic testing or counseling in these cases of autism? It's a question by Dr. Wong here.
Okay. So so it depends the autism, is it just autism or autism with intellectual disability or autism with some other conditions? So a lot the yield of autism, the yield of the testing of autism unfortunately is not high, especially when just a pure autism. So if your autism will add on with something, then likely there is another genetic condition. But I must say that the yield is not high for for autism. So I guess you can do the karyotype, do a Fragile X if it's a boy, and then you can refer on you if the parents are keen for genetic counseling and genetic testing, because I mean we still can talk to them whether they want a chromosome microarray and whole exome sequencing. Then they can weigh up the pros and cons, whether they want to know or not. And especially for those who is planning another pregnancy, then the risk of recurrence is there. When you have one child with autism, the risk of getting another child with autism is actually higher. I can't remember at this spot what is the percentage suddenly.
Thank you, Dr. Moy, for your answer. Then I have another question for you. I wonder if Dr. Moy still remember I think 2 years ago, we have referred a case of a boy named Falah to Dr. Moy. During that time, the child presented with hypotonia, central hypotonia, and then the child seems to be progressing. And then eventually the child required raw tube feeding. But at that point, because we still are waiting for, I think
Falah Wasim, is it?
Sorry?
Falah Wasim, is it?
I think so. I think Dr. Moy still remember the case, right? And we referred to neuro eventually. Then
Yeah. Neuro co-management.
do you think, Dr. Moy, our referral is because sometimes we need to do the chromosomal study, sometimes because the mother, I forgot the parents whether they are willing to pay for the preterm Penang or not, but chromosomal study usually will take time to come back to us. So Dr. Moy, do you think that is it okay with, because Falah's feature doesn't fulfill any kind of genetic disease
So-
that we know of lah.
Yeah,
Is
so
that-
for this Fala case, I think if, I mean, so you see for Fala case, I think his condition is like progressive, progressive deteriorating. It's like neural regression, something like that, right? If I
yes,
Is correct or not? The boy with some hypotonia and cannot find reflexes one, right?
Yes,
So
yes.
he is progressive. He's progressive deteriorating. So I mean, for like those like you think is urgent one, then probably you it's better to discuss with one of us, no, to see to see the child earlier, lor. Because I think Farah was I think he's like progressively worsening.
Yes. So from one,
I think
so
like
if without if even if without any chromosomal study, you still think that in those cases we think is suspect with rare disease, you still suggest us to refer you even before we get the chromosomal study, is it?
so okay, so it depends also on the when you can get the chromosome test done. No? I mean you can if you suspect a patient having rare disease, you can send the chromosome first and then while waiting, also getting the appointment. So when we see them at time, then we have chromosome study already, ma.
Okay, Dr. Moy.
Because actually, I
Mm.
mean, I must say that a lot of times actually the parents can't pay lor,
Yes.
pay for the subsequent tests. So Farah Wasim was quite was that time because he got a free testing that time. So I think Farah got the answer for the family. Yeah. Correct.
Yes. Thank you, Dr. Moy, for that answer.
So usually sorry, I just want to make a note that now so for the referrals, a lot of time the doctors will email the referrals right to the mailbox, and you must know that the mailbox is basically checked by the nurses. The nurses will just print out the referral and they just give the appointment like that. So no one really look through. I mean, we are not. I mean, we don't even we don't have time to go and sit there and then go through all the referrals. No. So if you think that the child need a earlier, need an earlier TCA, or you think the child is very ill, can't wait, or something is important that progressive, or then you call one of us lor, to see how to go about it lor.
Okay, thank you, Dr. Moy.
Hi, Dr. Moy. I'm Lavinia here.
Hi, Lavinia. Yeah.
I just want to ask you, so like last time when we see patients with Fragile X or DiGeorge syndrome and all, we can easily order the test from IMR. Is it still possible for pediatricians to order directly, or do they still need to go through the geneticists before ordering these tests?
Okay, I think they want like spoken to like that lah.
So it's just if we suspect, then we just give you all a call and
Yes. So
Right.
so you call the clinic, then just talk to one of us. Then usually it's okay. Yeah, yes, they just want to make sure that you spoke to a geneticist so that hopefully the chance of picking it up is a bit higher. So yeah, because the tests are basically is not cheap lah. The tests are not cheap. The fish is not cheap. The fish is like 1,000 per test like that.
okay.
And the sequencing all also take not cheap.
So in these cases, we don't have to email you. We just call you up and talk to you. Should be okay.
Yeah. I mean, if you need to talk to us one, then have to talk lor. If it's like not urgent cases or that, then you can go through email, because the thing is we don't check the email, because sometimes I think that sometimes the nurses will show me how come the doctors ask her question like that. Then that's why lor. I mean in genetic we don't go and check the email. Basically the nurse will just check the email and print out everything, trace whatever investigation from the referring doctors, then give the appointment. Itu saja. So if you think that it's urgent, or you think that can't wait something, or no, then
Actually,
have to.
our issue here is more of like sometimes the parents don't want to go all the way to Penang. They would rather stay here. So
So it depends. So it depends. Whether they want to this one or not, or counseling, all that lah.
okay. Thank you.
Thank you, Dr. Moy.
Thank you. Thank you.
If there are no more questions, thank you so much, Dr. Moy, for the information that you have provided. And now maybe we'll move on to another topic of the day.